So I'm going to speak on our work on cord signal changes in the absence of compression. I think we keep encountering patients with myelopathic patients. They present sometime to us, but the cord signal, there is a change, but there is no I think first timer and first slide also, title slide is missing here. Anyway. Yes. Can you start? Yeah. So cord signal changes without apparent compression seen on MRI is a quite disturbing to the surgeon as well as to offer to the patient, because these patients pose a diagnostic dilemma, and also decision making is always a problem in these patients, because we tend to treat them as a non-compressive myelopathies. This patient is myelopathic, but there is no compression on MRI, and what kind of treatment options we are going to provide this to the patient is also a big problem. So the typical example of a patient like this who presented to us with myelopathic symptoms for the past 6 months and has been approaching different yeah, sir. And the patient presented with, and that is the MRI. So these are the situations when we face with this kind of problem, then we have issues how to diagnose them. So the entire treatment of cervical myelopathy depends on what the MRI shows. The MRI has been the gold standard, and also comparing with the clinical pathology. If you say this first case, you might opt for a minimal invasive ACDF or foraminotomy, and the second case posterior decompression, third one may require anterior, and fourth one require a combined procedure. But all these MRIs belong to the same patient taken in different positions. In sitting, that's what made us to think about what's happening to this scenario. So the first one is taken in supine, and second one the patient is sitting neutral, and the third one is the patient is in flexion, and the fourth one is the patient in extension. So compared to the supine to the extension, we might think of doing a single level MIS procedure in the first patient, but if you know that patient is actually having what is seen on the last, the fourth film, your options of MIS might quite change in this scenario. So this reveals the concept of diagnostic stenosis, dynamic stenosis, which is quite popular nowadays, and then a lot of knowledge is largely available, but it's completely unknown about the dynamic behavior of the cervical spine, especially the ligament of flap and the disc. And it has got a tremendous impact on the management and outcome of these patients. So we have an access to this kind of MRI where we can make the patient to make patient sitting, and we can have the head loading on and ask the patient to in the flexion and extension we can get an MRI. So the amount of head weight, which is approximately 6 to 10 kgs depending on the person, can have a loading on the axial compression on the spine, and that can reveal the occult compressions which are pre-existing. This is how we take in the 3 positions. So study sample, it's a very, very highly selective patient population which you have included in this patient study. 15 patients who had signal changes but no compression seen on the supine MRI. And the average age was 53, 10 were males, 5 were females, and average score of JOI was that. This is the distribution of the patient. The commonest level which we noted in the study was C34. This was quite interesting for us to know that C34 was the commonest level where the signal change without apparent compression was there. And 4, 5 and 5, 6 were the other levels which are involved. Then we classified these patients basing on the Mole's canal stenosis grade in supine, neutral, flexion and extension. This is a classification which we have found out. Compared to the neutral, the grade, compared to the supine to the neutral, how much the grade changes, and in extension, how much the grade completely changes. Coming back to the original patient whom we have actually initially presented, so this, you can see the signal change which is there at 3-4 level, but if you subject this patient to the sitting MRI, you can see a dramatic change which is happening exactly at the level of signal change and causing the cord to compress. So now we are convinced that this patient is going to get benefited with your surgery, MIS, anterior, posterior, whichever way you want to do it, but the diagnosis is being established in this patient. The few other examples, the supine MRI, you can see the completely patient sitting in the neutral, significant compression happening at the level of signal intensity changes, and sitting in flexion somehow relieves the compression, and sitting in extension completely causes the ligament of flap to buckle in a level above also. So the effect of axial loading on the neck movements, there is significant change. You can see the C34 level, which is completely normal in the supine. You can see a significant compression happening at that exact level. So we try to compare these things in supine, flexion and extension. Different parameters was used. In comparison of study, we took the measurements of the adjacent segments, above and below segments, and compared to the level of signal intensity change. But we also know that axial loading can cause effect in the normal segments as well. So we compared the adjacent segment along with the existing segments. Coming to the disc bulge, which you have measured with this kind of approach, where you can see when the adjacent segments were prolapsing more than 16%, the affected level, it is actually the compression is 48% compared to the supine, the increase of percentage of disc prolapse. Similarly, the ligamental thickness in the adjacent segments, in extension it was 18%, and in the level where there was a signal change, you could see 30% increase in the ligament of buckling, which is causing a pincer grip kind of effect happening exactly at 3-4 level, which was completely free of compression in the supine. And the sagittal spinal canal diameters were measured in the way, and you can see that in adjacent segments there was only 3% narrowing of the sagittal canal diameter, but at the level of compression, at the level of signal change, you can see 14% in sitting neutral. Just by sitting neutral and in sitting in extension, you could see 12% increase, as the adjacent segments are only causing 1% increase. Cord cross-sectional area was measured in all the levels, and there is a significant increase compared to the adjacent segments versus the level which there is showing the compression. And the amount of compression and the area where it compresses also, there are a lot of interesting findings which you have found out. If you see, if you usually expect when there is a disc prolapse, you expect the signal change to happen at the level of the disc prolapse. But interestingly, you can see that level of one level down, and that exactly the area of signal change migrates to the area of disc compression when the patient flexes, and it migrates down when the patient is in extending. So there is a kind of dynamic compression which is happening at the level of disc prolapse, and in the sitting in extension, it's causing stretching of the cord against the disc prolapse and causing the myelopathy change. And also in the extension, we could see there is a pincer grip effect exactly happening at that level. So how can you approach this information? How can you put it in a regular practice? Because access to this kind of MRIs may not be available everywhere. So there were attempts initially also to get a flexion extension MRIs in the supine. But we also compared these values with the supine versus the loading on the sitting. So we could see significant difference by just sitting with the head load on without any neck movements. So we thought of having a kind of situation where we can we really recreate the head load. So these kind of harnesses are available. But we came to know it's interesting. These are the exercise equipment which the trainers use. So we started applying this head compression band and in the MRI, supine MRI, and applying the weight onto the foot end by applying a traction device and a saline water bag, and started to know whether there is any significant compression which can be noticed. We are able to show some compression but not very significant. So to conclude, first time we have documented the changes of signal intensity changes. C3-4 was the predominant level. Ligament of long buckling and disc bulge were over inflection and extension, and this has got tremendous implications on the diagnosis and management. Thank you very much for your kind attention.